Okay, so let's switch gears a little bit and talk now about anesthesia and the different types of anesthesia and what it does to the brain and so on and so forth. And before we talk about anesthesia, we should really emphasize how amazingly lucky we are that as people in the history of all mankind and all humanity, that we are alive at a time when anesthesia is readily available. Because it is likely that at some point, most, if not all of us, will be anesthetized at some point for an operation. Because, and I say this because surgery before anesthesia was terrible. There were literally men, strong, burly men, whose job at the hospital was to hold people down while they were getting surgery because there was no anesthesia. There was no way to numb them. There was no way to put them asleep. At many hospitals, they would put the surgical suite on the very top floor. Why would they put it on the top floor, you ask? Because the screams would be so loud that it's not really, good for business and recovery and hospital work in general. If while, you're delivering a baby or going to speak to the doctor about any problem you're having, if you're hearing the pains and anguish of someone having their body cut open for any variety of reasons. A lot of people who, and this is, thousands of years of reporting, would have permanent emotional damage after having surgery without any anesthesia. They would be traumatized by the sounds of surgery often, hearing their bones get sawed into, hearing the scalpel cutting into their flesh, hearing their organs being squished around. A lot of them also were really traumatized by the smell of their own internal organs because, your insides do in fact have a smell. And there were no painkillers back then. And, sometimes I have students ask me a question about could you get inebriated? And the answer is no, not really, because, during a lot of surgeries, you don't, how before surgery, you don't want people to eat or drink for a certain period of time because you don't want their body to be processing things because that can lead to more complications. So no, they wouldn't really want you to do that. And they wouldn't, so they didn't really have anything to kind of help numb the pain. And it was such an ordeal, actually, that was not uncommon that people would actually commit suicide rather than getting surgery done on them, because they were just like, I would rather no longer live than have to go through what could potentially be a life-saving procedure. But that is, terrifying to imagine having, your body cut open to have, say, a tumor removed or something like that. But then in the 1800s, this guy who was a dentist, William T.G. Morton, was a doctor who noticed that people who were recreationally inhaling ether, like almost as like a after-party endeavor, we'll say, we're getting a little loopy. And sometimes you notice that some of these people in these recreational events would have so much of this, would inhale so much of this gas that they would actually pass out and couldn't be resuscitated. So he then developed this idea of creating ether as a form of anesthesia. And it worked remarkably well, where once they started having people inhale anesthesia, or inhale ether rather, they would be unconscious. They would stay unconscious for a while. You could do a procedure. You didn't need to hold them down. They would often not remember it. They would not feel the pain. They would not do anything. So this is an amazing medical breakthrough that doctors have built upon. We now have a bunch of different types of anesthesia, and we're going to talk about some of them. But by and large, it's actually not crazy to say that there's a lot of mystery about how anesthesia works. There's this book by Kate Cole Adams where she quotes someone who was a physician who was saying, when I first got to medical school at Stanford, this was the one problem I wanted to solve. Anesthesia is of such practical importance that I couldn't believe we didn't know how all these anesthetics could cause people to lose consciousness. We know it works, but we do struggle in a lot of cases to know exactly how. And sometimes actually this can lead to really unfortunate consequences and side effects. People can get damaged. There's issues where you think they're anesthetized, but they're not. You can have problems. People can die because they will stop breathing. And so it's one of these cases where it's like, well, we know it works and it seems like it's worked so well. And if we do it this way, history tells us it works well, but we don't always necessarily know how. It's certainly not that we don't know anything. And I'm going to tell you a little bit about what we know. We do know a good amount, but there's a lot of mysteries about anesthesia, even to this day. Okay, so when we're talking about anesthesia, we'll talk about the different types of anesthesia, the different risks associated with anesthesia, and then at the end, we'll talk about some of the hallmarkers of what's going on exactly with anesthesia and the brain. So let's talk about the different types of anesthesia. The three main subgroups are local, regional, and general anesthesia. Now, local anesthesia, I'm sure a lot of you have probably maybe even had local anesthesia. This is the sort of thing that you get when you're, say, having some, stitches put in, if you cut yourself, if you have a laceration, if you have to get like a cyst or a mole or something removed, they might do a little local anesthesia so it doesn't hurt. Local anesthesia is probably used most commonly for those people who've had it in dentistry. If you're getting tooth worked on, you'll sometimes have the anesthesia injected above the tooth, and then it will numb the teeth underneath it. And the way that local anesthesia works is that they'll literally inject it into part of the skin. It lasts for a relatively short period of time. And as far as the fluid, the anesthetic fluid dissipates into the tissue, will be the amount of tissue that will be anesthetized and will be numbed until the effects wear off because it gets metabolized by the body. And the way that local anesthesia works is that normally, we talked weeks ago about these sodium-gated ion channels. And what the local anesthesia does is it will actually take a healthy sodium-gated ion channel, or a sodium ion channel, and it will effectively block it. So lidocaine is a very common local anesthetic. It's often used in dentistry, for example. And what lidocaine will do is will literally block sodium from passing through the channel. And if it can't get through the channel, there will be no polarization. And you can get it to therefore not polarize for specifically neurons that are infected in things of like transmitting things like pain signals or somatosensory signals. So basically, if you just literally block these sodium channels, then the signals that would normally be transmitting pain to the body just won't be able to do it because the neurons themselves are not going to be able to polarize. And if they can't polarize, they can't signal into the brain. And if the brain's not getting the signal, you're not going to feel any pain. So it's actually relatively simple. So that's local anesthesia, but sometimes people do what is called regional anesthesia. And this is where you will actually inject the anesthesia near a nerve cluster to numb a general area of the body. So you can do some nerve bundles that will make it such that, for example, your entire arm is numb. People have an epidural in their spine and when they're giving birth sometimes. And so basically their entire lower half will be anesthetized. You can get more specific. So it's part of not just one limb, but part, the hand of one limb in particular. And it actually turns out that it's pretty well understood that if you inject the anesthesia in these different, between these different vertebrae in your spinal cord, it'll be useful for different types of surgery. If you're having something done to your pancreas or your esophagus, you'll want to do it in this middle section. If you're doing stuff for your lower abdomen, you'll do it there. They have a pretty good understanding of how these nerves kind of go from the spine into the rest of the body. And so they know exactly where to hit to numb a whole region of it. And in fact, actually, with more knowledge of these nerves, for example, in something like your arm, you can actually really get even more precise to numb specific parts of your arm if you need to do specific types of surgery. So this is true across your entire body. So regional anesthesia is basically a type of local anesthesia, except they target particular nerve bundles to hit whole regional areas. And this is, if you're having some sort of orthopedic surgery or a tendon repaired or something like that, you wouldn't want just to pour tons and tons of local anesthesia into someone's ankle. Instead, you would just try to get it near a nerve bundle. And then the big one that I want to talk about is, of course, general anesthesia. General anesthesia is what I think a lot of times people think when they think of being like you're going under anesthesia. You lose consciousness, you're effectively asleep for a while, although there's much more to it than that. We'll go into that in a second. One common form of general anesthesia is inhaling nitrous oxide. Another is you get an injection, which can be something like a drug called propofol or ketamine. But general anesthesia actually isn't just one thing. It actually has many different properties. There is that the drugs do a variety of independent factors. So one part of the drugs will lead to a loss of consciousness, but that's not enough because, if someone fell asleep, for example, and they lose consciousness during surgery, if you cut into them, they'll wake up. So, you need to do other things. For example, other things that you can do is have parts of it that will shut down the hippocampus and therefore cause you to be amnesic. It's not uncommon that people with anesthesia will sometimes wake up and say or do things in the surgery, but then you kind of calm them down, maybe hold them in place for a second, and they'll go back to sleep and they'll have no memory that they did that because of the amnesic properties of the drug. Similarly, they will have analgesic properties, which is just basically they will numb certain parts of you. So this is, for example, a differentiation between being asleep and anesthetized. If you cut into someone while they're asleep, they will wake up. If you cut someone under anesthesia, they won't, in part because of the drug-induced loss of consciousness and the drug having an analgesic properties. And then another is akinesia, which would basically then be a motor inhibition. Because you can certainly, again, draw a parallel to sleep, you can certainly move around and sometimes thrash around in your sleep. That'd be really bad during surgery and when you're in a particularly vulnerable state. But then critically, all these drugs also, while they do these four things here, they will also preserve the stability of certain critical physiological systems: heart rate, respiration, body temperature, and so on and so forth. And you obviously need to keep someone under anesthesia and turn all these systems off, but keep those vital systems in check for them to have a hopeful recovery. And to give you a better sense of, just to relate it to what we were talking about a couple weeks ago, when we were talking about neurons innervating the motor system, one of the things that I talked about is that you can have motor problems because of these immune disorders. But I also wanted to just remind you that we talked about one drug, rocuronium, which is a part of anesthesia. That is part of the akinesia that I was talking about that will prevent the movement, is because this drug will kind of block these neurotransmitters from innervating with the muscles, and so the muscles will be inhibited. Just trying to make sure to tie these things together across the weeks in the course. There are, of course, certain types of risks with anesthesia. So for example, with local and regional anesthesia, probably the biggest risk is nerve damage. If you're getting an epidural, for example, and the physician unfortunately, hits your spinal cord, that can lead to permanent nerve damage. If you're even getting it in your mouth for a tooth and they get close to a nerve or sever a nerve, that can lead to either chronic pain or chronic numbness. With general anesthesia, the risks are higher in the sense that they might not happen as frequently, but when they happen, they can be terminal because, for example, under general anesthesia, sometimes people's heart will stop beating, their breathing will stop. And actually, it's been shown in the last couple of years pretty consistently that for people who are older, 65, 70 and older, it's not uncommon that after being put under general anesthesia, they will have permanent cognitive loss. They will lose some IQ points, their memory capabilities. And so actually there is, sometimes a concern about if people are having health problems as they're getting older, there's a reluctance to have them go under general anesthesia again and again, because they sometimes come out of it and they're not exactly quite the same. Similarly, and I think I've mentioned this before in class, and you can find, I just Googled this, awake during surgery, and it just popped up real quickly online. These stories of people where the anesthesia doesn't work, and it will work as not an anesthetic, but as a paralytic, where it will paralyze them rather than anesthetize them, but a person will be unable to move, scream, talk, or give any indication that they were awake while they had been paralyzed. And so to get a sense of how to avoid these certain types of things, scientists have certainly tried to understand what are the hallmarks of what an anesthesia is doing to the brain. Because if you understand those hallmarks, maybe what you can do in the same way that we're able to look at waveforms in the brain and understand when you're asleep, and maybe we could look at waveforms in the brain and understand when you're actually anesthetized, to differentiate between an anesthetic situation and a paralytic situation like this one right here. So when talking about anesthesia in the brain, we're going to focus a little bit on just how some of it works and what some of these objective measures are that allow you to know that a person is actually unconscious. So one of the ways that it actually works is similar to what we've been talking about with alcohol and insomnia related to the GABA system, except in this case here, rather than it being something like a benzodiazepine that's going to help facilitate GABA to let the chloride in so that the neurons will turn off, there are anesthetics that do it. So for example, perhaps the most well-known general anesthetic is this drug called propofol. And actually propofol, for those of you who might not know this, Michael Jackson died because he was taking propofol recreationally to go to sleep. I think he had a doctor who was not a very good doctor administering propofol to him as like a sleep aid rather than taking a Tylenol PM or some melatonin. He was getting injections of propofol, and I think that the measurements or the way it was injected, there was complications from it, and actually he died in his sleep from propofol complications. And propofol actually works by helping to facilitate this GABA system. So normally without the anesthetic, you have a certain amount of chloride outside the nerve, and some of it will go through a GABA channel like this. But it actually turns out that with anesthesia, you can have a drug like propofol or sevoflurane, which is just another type of drug, that basically mimics the GABA system as well. And by mimicking the GABA system, you can inject it into a person. All these channels will open up, the chloride will flow through those, and those will inhibit the neurons. And so if you do a slow and steady dose of propofol, you can inhibit the neurons enough such that a person is rendered unconscious and put in and is anesthetized. Another common drug is called ketamine, and this anesthetic does not work on the GABA system. It works on an NMDA system. And so in this case here, this receptor, the NMDA receptor, lets sodium out, and then that's what the K is, but then lets potassium and calcium in, and the more this receptor works, the more the neurons fire. So the more the NMDA system is open, the more the neurons are firing. And so basically what ketamine is going to do is ketamine is just going to come in and just block that system so that there can't be that flow of ions. And so since those neurons aren't going to be able to fire, the lack of firing neurons is going to have these certain, anesthetic effects. So that's what's happening on a local level. Those are just two examples of how it works. And so let's take a little step back and talk about objective measures that a person is actually unconscious. And again, we can do it by looking at electroencephalographies. And so what I'm going to do now is I'm going to play you this video by this anesthesiologist named Emery Brown. And he's going to walk you through a person getting anesthetized. And these are their brain waves. We're just looking at 4 brain waves for this little individual. And so he'll kind of narrate how it's changing as this particular woman is getting an injection of propofol. So let's check it out.
Propofol. I'm going to give her about 150 milligrams of it. And we're going to watch her brain waves as they change in real time. So there are 4 brain waves that you see there, 4 electrodes. So there are 2 on the left, 2 on the right. That's why you see 4 traces there. And we're just going to watch what happens as she receives the propofol. I'll talk you through it. All right? So at the moment, nothing's happening. So that's just her lying there, kind of at rest. And if you've never seen EEG before, those are eye blinks. Okay? Now what's going to happen now, I'm going to inject the propofol. And propofol burns when it goes in, particularly if you inject it into a small vein, like the one on the back of my hand here. So that's what's happening. And so she's tensing up like this. She's tensing up. And you see there's a lot of noise, all right? Now that's actually going to be good from a pedagogical standpoint because you're going to be able to see exactly when the drug takes effect. So give me another 6 or 7 seconds here. So look at all that noise. She's tensing up. She's tensing up. Now watch what happens right here. Boom. See those oscillations, right? They're going to get bigger. The drug is taking over. It's turned off her brainstem, and now she's become unconscious, right? And now watch, they're going to get even more profound. They're going to go flat and then burst. Flat and then burst. So she is now in a drug-induced coma. She has to be in a state like that so she can undergo surgery.
Okay, so one thing I do really want to point out, or this is just a fun anecdote, is notice he said it takes like 6, 7, 10 seconds. So I've had to go under propofol-induced anesthesia a couple times, and a few times that I do it, I always tell them that I'm a neuroscience professor, and they get kind of a kick out of it because I always ask them, will you tell me when you have injected it into me? Because I'm going to try to resist, okay? I tell them I know for some people you bring them in and you're like, count backwards, just relax to help you drift off. I'm like, no. I'm going to try to see how long I can hold on for. And it's just amazing because I'll be anesthetized, or they'll give it to me and I'll be like, okay, feeling all right. I'm feeling good. And then it just hits you. And then all of a sudden you wake up and you're like, wait, the surgery's done. What do you mean the surgery's done? Because even when someone like me tries knowingly to resist it as much as I can, I'm still not really able to. Anyway, so what is often now the case is that patients will not infrequently be monitored with an EEG, depending on the type of procedure that they're getting done, so that they can see these sort of changes in the waveforms, much like we would see in sleep, to know exactly when the person has entered a true anesthetic unconsciousness. Okay, so another question to wonder, though, is if there are other neuromarkers of anesthesia, which actually are sometimes used for sleep and vice versa. And there certainly are. And to understand these, though, we'll go away from EEG and we'll start talking about a little bit about network computations in the brain. And so what we're going to do in the next video, in video 5, is going to be talking about other neural markers of anesthesia and sleep with a focus on networks rather than just on EEG. So let's take a little break there.